All right.
Hi, my name is Apostolos. I'm a cardiologist in Greece. So I think this will be your first bypass graft case, probably. This one we're going to discuss today together. So 65-year-old male patient with chest pain. He presented with chest pain and lateral T-wave inversions on the ECG, had no trop rise. In terms of his past medical history, he has a previous bypass graft. We know what the grafts are. He had the Lima to LAD, a venous graft to his RCA, and a venous graft to his obtuse marginal branch. A decision was made to proceed with cardiac CT. So let's load this study, please, and review it together. Okay, so we know what the grafts are. Sometimes we don't get this information, unfortunately, but here we know that this patient has had 3 grafts, a Lima and 2 venous grafts. So I don't know if you have a process in your mind as to how to approach a bypass graft case, but I usually start off with a native coronaries. It may be simpler than what you expect because usually the native coronaries are heavily diseased. They have a lot of calcium. They may be unavailable or they may have CTO. Okay. So looking at the axial images, we can find the LAD, we can find the circumflex, and we can see the RCA ostium. So the first step when I assess a bypass graft case, I look at the native coronaries, as I said, which I expect to be heavily diseased, as it is in this case. So here you see the left main, which looks fairly unobstructed. But then look at the LAD, how heavily diseased it is. There's a lot of calcified plaque, and then it becomes occluded proximally. That's very, very common in bypass cases. Similarly with circumflex, you can see that it gets occluded at this proximal segment. And if you look at the ostium of the RCA, which comes off from here, you will see that it is occluded ostially. So we know that there's heavily diseased native circulation. And then you have to look for the grafts, okay? The surgeons attach grafts to the ascending aorta usually, and they can be either venous or arterial grafts. Knowing what grafts the patient has got, I start looking for them actively. If I know that they have a Lima graft, I usually start off from the left subclavian artery and look at the Lima, okay? So if you go up in the chest and find the left subclavian artery, and then gradually scroll down with the middle button, you will see this artery coming off the subclavian, which is the left internal mammary artery, okay? This usually runs on the chest wall, but here it has been mobilized. And if you follow its course down towards the heart, you will see that it gets attached somewhere, okay? Usually it's the LAD. Now, this may be more obvious if you do a MIP, okay? I don't know how to do a MIP here. Right click maybe. So I use a different software where I work. Okay, fine. So this may be more obvious, okay? The artery is this one. This is just an anatomical image to see where the arteries go. Okay, here you follow it and goes to the LAD territory, okay? Okay, so that's the Lima, okay. Now, if you want to assess this vessel properly, you go back to your thin slices there, and you have to manually track them with a CPR. Okay, shall I give you some time to try and track the Lima graft, okay? Start from the left subclavian. Okay, so let's do it together. Okay, so, all right, so I will track the Lima graft, okay, from the left subclavian. Okay, and that's my Lima graft, okay? Right. Obviously, we look at the curved MPR as well as the orthogonal cross-sectional view here in the short axis. Okay. It's important when we have a Lima graft or with any graft to look at the proximal and distal anastomosis because these can be often areas of stenosis. So we have to make sure that our our center line includes a bit of the subclavian artery, so we can assess this proximal anastomosis. And yeah, here you can see it gets attached to the distal LAD. You see that the LAD appears like this here. It's heavily diseased. This is the distal anastomosis down here. And that's the distal runoff, okay, which has some mild stenosis. Obviously, we look at that in the cross-sectional views like this. So mild disease, distal LAD, distal runoff, and unobstructed Lima graft with patent proximal and distal anastomosis, I would say.